Good morning. It is May 26, 2022. We're going to go ahead and get started, you guys. This morning's topic is managing a difficult airway with our PACU resident, Rachel Ryan. And we are, I think, ready to roll. And then you can either use the arrows or yeah, or like down here, you can go that way too.
They work. All right. Perfect.
Maybe all sign, make sure you sign in.
That was so bad. All right, cool. Well, so the topic we're talking about this morning is managing the difficult airway, which is a pretty big topic. So I'm Rachel. The outline today is to start with some background on airway anatomy, defining what is a difficult airway, and then how do we predict who's going to be difficult. Talking about how we manage difficult airways in the operating room, both in patients after we induce anesthesia, and then people who we choose to manage their airway when they're awake before we induce anesthesia. And then really talking about kind of how we recognize people who might be difficult and manage them in the PACU, which is obviously going to be the most pertinent to all of you. So just as a little bit of background, just a reminder about the airway anatomy. So the airway starts with the nasal and oral cavities, which come together to form the pharynx. You have the epiglottis, which kind of forms the opening into the larynx, kind of closes and separates the larynx from the esophagus. And right below the epiglottis is the glottis with vocal cords, which is what leads into the trachea, which is your upper and lower airways. So why do we have to manage the airways of our surgical patients? So when our patients come in for surgical procedures, they come in awake and alert, and they progress along this continuum from awake and alert to maybe light anxiolysis, some light sedation, deeper sedation, and for most of our patients, general anesthesia. And as we progress along that, there are physiologic changes that come with inducing these levels of anesthesia. So maybe with light anxiolysis, you might just have some loss of muscle tone in the tongue and the soft tissues that kind of surround the airway. But as you progress into deeper levels of sedation and general anesthesia, and certainly as you administer paralytics, there is depression of the respiratory drive and development of apnea. And so patients need to have their airways managed by us. So there are different options for how we manage the airway depending on kind of where the patients fall on this continuum. So an awake alert patient has unsupported spontaneous breathing. Somebody who is just receiving some anxiolysis or light sedation and they just have a little bit of collapse of their upper airway muscles might just need an airway adjunct. They're breathing spontaneously, but they're going to do okay as long as we kind of get that soft tissue out of the way, and that's when we might use an oral airway or a nasal airway. Patients who are at deeper levels of sedation or under general anesthesia where they're not breathing spontaneously or not making adequate spontaneous breathing are going to require some kind of non-invasive ventilation. So we can start with bag mask ventilation, also placing a supraglottic airway, which is we commonly refer to as an LMA, or endotracheal intubation. And then finally, they can also have an invasive airway, so that would be a transtracheal or a surgical airway. So what defines a difficult airway? So the definition of a difficult airway is a patient for whom it's difficult to achieve face mask ventilation or endotracheal intubation. When we think about those patients, so they there's these two different categories, and patients can exist in one of the two categories or they can overlap. So you can have a patient who is difficult to mask ventilate, but if they're not difficult to intubate, we're able to intubate them. And likewise, you can have a patient who is straightforward to mask ventilate, but we have difficulty with intubation, whether that's with achieving a view to pass the tube or with the physical actually passing the endotracheal tube. And both of those categories of patients give us an option to manage their airway, right? You have, if they're difficult in only one, you have the option of the other category. Where it becomes most scary is when patients overlap kind of in that middle zone and we have difficulty with mask ventilation and with intubation. Then there's no good way to manage the airway. And so when, the way that I think about it, when we're evaluating patients preoperatively and thinking about, is this person going to be a difficult airway? I think the question kind of in the back of our mind is often, if I induce general anesthesia in my patient, so I take away their spontaneous ability to breathe, can I oxygenate my patient? Can I manage their airway in some way once I take that ability away for them? And I think that's really what this kind of boils down to. So how do we know who's going to be difficult? So there are a lot of patient-related factors. People who have a history of being a difficult airway are likely to be difficult again. Certain medical conditions. So people who are undergoing head and neck procedures, particularly if they've had neck radiation and there are changes to the airway or the adjacent structures. Anybody who has an obstructing mass near the airway, like big thyroid goiter as an example. Patients' physical characteristics, which we'll talk about in a second when I'll talk through kind of our preoperative examination, but patients who are obese, who may have kind of a thicker obese neck or otherwise limited changes in their neck anatomy. And then there are characteristics on the airway exam that I'll talk about. And a patient's ability to cooperate is another factor that becomes important when we start talking about options for managing their airway when they are awake. If they can't cooperate, it makes it difficult. And then there are factors related to the actual procedure the patient is undergoing. Again, it's if the procedure is going to involve the patient's airway, if it's going to involve adjacent structures, such as their neck, or dental procedures in the mouth, on the jaw that are going to limit our access to the oropharyngeal cavity, might also impact our airway management. And then the urgency of the procedure also plays a role because it limits some of the options that we have for managing the airway. And so there's a nice kind of way to think about patients. Dr. Healy wrote a nice review, kind of a refresher on difficult airways. He's one of our anesthesiologists here. And when we look at patients in pre-op, you can kind of fit them into these three categories. So you have patients who you look at all these factors related to their history, their physical characteristics, and the procedure, and you say likely they're going to be an easy airway. And then you just proceed with general anesthesia and use standard equipment. For patients who have a lot of these risk factors, a history of a difficult airway, or a lot of factors that you feel like they're likely going to be difficult, then you can kind of say, okay, well, let's proceed with managing their airway while they're awake before we induce general anesthesia and take away their spontaneous drive to breathe. And then the tricky category, the patients that fall kind of in the middle, where they're at higher risk, they have enough factors that they're not going to be easy. We think they might be difficult. And those are the patients for whom we come up with a series of plans, kind of A, B, C, and D for managing their airway. And we'll talk through kind of some of the common ones that we use. So I just want to talk about what we look at in our preoperative assessment of patients. So this is part of our centricity H&P, and it's the physical characteristics that we evaluate in all of our patients preoperatively. So we evaluate their dentition, whether they have a beard. We look at their mouth opening. We give them a Mallampati score. So we say, sit straight up, open your mouth as wide as you can, stick out your tongue. And we give them a score of 1, 2, 3, or 4 based on the visibility of the uvula. So a score of 1 is where you can see the entire uvula, 2 is partial view of the uvula, 3 is where you can see the soft and hard palate, and then 4 is where you can only see the hard palate. We also look at the distance between their theromental distance, whether they have any limitations on their cervical spine motion, other characteristics of their neck anatomy, and whether they're able to protrude their lower jaw out in front of their upper jaw. And the reason that we assess all of these things is because they are established predictors of difficulty with airway management. So these tables, I don't intend to read through all of these, but they're established predictors of difficulty with both face mask ventilation, which is what's listed on the left there, and then predictors of difficult direct laryngoscopy or intubation. And what I kind of just want to highlight is that there's a lot of overlap between these factors, and a lot of these things are what we assess on our preoperative physical examination. So in particular, patients who have limited mandibular protrusion are difficult. or that can predict difficulty. Having a modified Mallampati score of either class 3 or 4 also can predict difficulty. And then characteristics that we encounter commonly in our patients here. So being edentulous, having a history of sleep apnea, having that history of neck radiation and limited neck extension, again, are all things that predict potential difficulty with the management of the airway. And so in terms of thinking about how do we manage the airway, just as like kind of a broad overview, I think that, the first thing is planning. So the first thing is recognizing this, that your patient might be difficult, and then having plans. So from an anesthesia standpoint, we don't just have plan A, we always have plan A, B, C, and D. So we're going to try this, and if that doesn't work, we're going to be ready to do this next thing, this next thing, this next thing, and have all of that available, have discussed it ahead of time. The next thing is being prepared. So having the equipment that we need for plan A, having the backup equipment for plans B, C, and D, and having it readily available in the room, being in the right environment, in an optimal environment if we can. So being in the operating room with the equipment and backup equipment. And then we think about optimally positioning the patient before we start to manage the airway. And we think about pre-oxygenation as a really key component, because as we start to manage a patient's airway, particularly after induction of anesthesia, there's going to be a period where we're trying to secure the airway where they're not breathing on their own. There will be a period of apnea. And if the pre-oxygenation helps us, gives us a little more time before the patient becomes hypoxic. And then lastly, bring your team. So having the right personnel in the room. And so that, if we anticipate difficulty, we'll often have multiple anesthesia providers, experienced anesthesia providers with the technique we're choosing. And often we call the otolaryngology team as well, if we think there's a possibility that we may need to have one of our backup plans be a surgical airway, we'll have them around as well. And so now I just want to touch on some of the most common airway management techniques we use in the OR. So to kind of break this down, again, we talked about patients kind of falling in those 3 buckets of either likely easy and we feel confident going to sleep, likely difficult and we feel like we need to manage the airway when they're awake, and then patients who fall somewhere in the middle. This is a nice algorithm from the Difficult Airway Society, and it essentially brings you through the exact same steps. I don't know if there's can you see the pointer okay on here? Essentially, this algorithm, starts out with, do we suspect difficult laryngoscopy or difficult intubation? And if the answer is no, then we can proceed down to the bottom there with airway management after we induce anesthesia. And if we suspect that it's going to be difficult, then we get pushed down that left side of the algorithm that says awake airway management. And so just to kind of categorize those things, I'll start on this right side and just say, let's talk about the options that we have for airway management after we induce anesthesia. So the first is standard direct laryngoscopy. So this is a procedure where we start with pre-oxygenation of the patient in the operating room and positioning. So important things to think about. Again, we talked about pre-oxygenation. So this is providing the patient while they're spontaneously breathing with pre-oxygenation through a face mask, with the goal of having oxygen displace the nitrogen that's in the lungs. Patient positioning is also very important. They need to be in what we call the sniffing position, and it's essentially a position that allows us to line up their oropharyngeal axis with our eye so that we're able to directly visualize the glottic opening. And you can see in that picture there's a the blade for a direct laryngoscope is placed in the patient's mouth. And apparently this is working in excellent. So you place the scope in the patient's mouth, and the goal is to use a direct visualization of the glottic opening, which you can see there, and place the endotracheal tube. And that's following induction of anesthesia. We have the picture kind of on the top there depicts an optimal glottic view where you can see the vocal cords, you can see exactly where you need to place the tube. Sometimes when we're performing direct laryngoscopy, the view of the vocal cords is suboptimal, and we also assign grades 1, 2, 3, 4 to the view that we get on direct laryngoscopy, and you can see those kind of along the bottom. So again, grade 1 being a full view of the cords, progressing down to grade 4 where you can't see you only see soft tissue and you cannot see the epiglottis. And so when we're performing direct laryngoscopy, there are maneuvers that we can use to try to optimize our view, which are, I'm not going to go into extensive detail. I don't think it's that pertinent to your PACU, but there are ways that we can optimize our view using direct laryngoscopy. And sometimes the other option is to proceed with video laryngoscopy, which can sometimes help improve our visualization of the glottic opening, particularly if patients have an anterior airway. And I think this is a nice illustration. If you start at the bottom there, you can see that the direct laryngoscopy relies on, again, that direct visualization of the glottis and the vocal cords. And if the view you're able to obtain with the blade doesn't really line up with the glottic structures, then you may not be able to see them. The video laryngoscope is this blade that has a camera on it. And so there are different types of blades with a different degree of curvature, and they essentially help give you a view of something that you may not be able to achieve with your eye alone. And that's what's illustrated in this top picture. So you can see this is giving you this limited view from the light source this way, but you really need your eye to be lined up with the view of the blade. And these video laryngoscopes, kind of the cameras here, and it helps give you a view on a screen of something that you might not be able to see with your eye. So that can be helpful. We can use either direct or video laryngoscopy to perform rapid sequence intubation, which we do, which is similar to, sorry, so I will back up and say, so this is performed sometimes, what I'm thinking, sorry guys. So this is performed when we pre-oxygenate the patient, we induce anesthesia, and we don't mass ventilate prior to attempting to place the tube. You can use, again, direct or video laryngoscopy for this. We do this sometimes for patients if we're trying to reduce aspiration risk. And also sometimes for patients, if we feel like we need to induce general anesthesia, we think their airway is going to be difficult, or they have very limited reserve, we don't think they can tolerate hypoxia, and they're not going to cooperate with awake intubation. Sometimes you may choose a rapid sequence intubation kind of as a first choice with a backup available. And then I want to talk about the other side of the algorithm, which is awake airway management. So these are for patients who you highly suspect they're going to be difficult, or they're going to be difficult. You choose to manage their airway when they're awake. So the standard that we typically talk about is awake intubation. We call it awake fiber optic intubation, and really it's now it's a digital scope, so it's not really a fiber optic scope. But this is the most conservative way to manage the airway. The important thing to know about this is that it requires preparation, it requires the patient to cooperate, and it requires time. So this is not something that can be done if the airway needs to be secured in a matter of moments. You don't have time to prepare the patient for awake intubation. This can be done nasally or orally. So what we do to prepare the patient is we give an anti-sialagogue to help dry up secretions. We use topical local anesthetics, so nebulized lidocaine, often lidocaine jelly, and some light anxiolysis to help them kind of tolerate having all these things in their mouth. And then we use a flexible scope, which is a digital endoscope, and we can pass it into the nasal cavity or into the oral cavity. We advance it all the way through the glottic opening, through the vocal cords, and down into the trachea. And then when that scope is there, we pass the endotracheal tube over the scope. And then once we confirm that we're in the correct place, then we induce general anesthesia. And the last thing is transtracheal surgical airways. So these can be planned, they can be unplanned. So this is kind of the last rescue option, often option D if other things fail. If you have some patient who you cannot mass ventilate and a patient who you cannot intubate, then the option is to directly ventilate through the trachea. What's illustrated in this picture is a cricothyrotomy, which is essentially making a small incision in the cricothyroid membrane and placing a bougie that helps you pass an endotracheal tube directly into the trachea. And that as kind of a rescue maneuver. There are certainly also planned tracheostomies for patients, and also patients who undergo a laryngectomy will have a tracheal stoma. So those are more planned surgical airways. So when a patient is difficult to either mass ventilate or intubate, the decision to extubate is carefully considered. We want to be sure that the patient is protecting their airway before we decide to take out our airway management device. So the things we're thinking about in the OR before we come back are they fully awake? Are they breathing spontaneously in an adequate fashion? Are they able to protect their airway? Can they swallow? Can they follow commands? If they've had paralytic, is that adequately reversed so that they're strong enough to breathe adequately? Are their hemodynamics stable? Are they normothermic? And is there anything physically obstructing the airway that would preclude me from taking out the tube? So do they have a mass? Do they have bleeding? They have swelling of their airway because they've had it worked on? Any of those things that if I'm concerned if I take out the tube, I may not be able to get it back in. And one thing that we do sometimes in somebody who's been difficult is if we're planning to extubate, we may temporarily place an airway exchange catheter in the kind of immediate postoperative period. And so what that looks like, we use the Cook airway exchange catheter quite often. And there's a picture of it here on the bottom left. It's just a kind of thin catheter. It's yellow. It has little markings on it, and it provides us basically a temporary conduit to the airway. So what we do is we will place the Cook catheter through the endotracheal tube and then extubate the patient by taking the endotracheal tube out, but leaving that Cook catheter in place. And so that tube has lumen, it has a lumen, it has support, so we can oxygenate the patient through there. And most importantly, if the patient is not breathing or not adequately ventilating and we feel like we need to re-intubate, we can place the tube back over that catheter, which provides us a way to get back into the airway. So the important things to know when patients come out to the PACU, you may see the catheter like this. So we use those markings and place the tube at a predetermined depth, which we will then tape it to the patient's face, kind of to their cheek here, and we write on it what depth the Cook catheter is taped at. So if you have a patient who comes out with a Cook catheter, this is what it may look like. And then the removal of the Cook catheter would be, if it were to occur in the PACU, would occur after discussion with the attending anesthesiologist. Typically, we would leave it in for a period of at least 30 minutes of observation to ensure that the patient is adequately ventilating. And then if we felt that they were safe, then we may take it out. But that's something that should be absolutely handed off to you if that were the case. And so now I want to talk about the most pertinent thing, which is management of the difficult airway in the PACU. So I had, kind of three main things to think about. Number one is be aware. So if you have a patient coming out, some patient risk factors to be aware of that they might be a difficult airway. So if somebody says in the handoff when you're getting the patient, they had a difficult airway, don't let that person walk away before you get some clarification, because what constitutes a difficult airway is a lot of things, as we just kind of talked about. And so getting some clarification helps with planning and understanding what they might need. Does difficult airway mean that they tried direct laryngoscopy and it was a difficult view, but they switched to a video and it was straightforward? Does it mean that they required an awake intubation? Does it mean that they were difficult to mass ventilate and they had difficulty with their view? All those things have different implications. So make sure just ask the person to stay a few more seconds and tell you what they mean if they say, oh, they were a difficult airway. Patients who have obstructive sleep apnea are particularly prone to having, again, that kind of soft tissue collapse into obstructing in the postoperative period, particularly when they're still somnolent as they're coming out of anesthesia and when they have narcotic medications on board. So patients with obstructive sleep apnea are ones to always keep a close eye on. Patients who have another reason for having reduced respiratory reserve, people who have existing neuromuscular disease, patients who are just older and frail, if they have reactive airway disease, people with systemic illness like sepsis. And then a lot of our patients develop some degree of postoperative atelectasis. and people who have reduced respiratory reserve just may be able to tolerate that less. So just being aware of all of those factors as your patient comes out can kind of give you a heads up to like this person's airway might be more challenging, might take more attention. And then what procedure did they have done? Again, did they have something done on their airway? Was it in the head and neck? Did they, have something where I'm concerned about some obstruction of the airway structures or swelling that might make things more difficult? Or did they have a procedure, like a dental procedure on their like TMJ surgery sometimes, or some other dental procedure where now their jaw needs to be wired shut and we cannot place a laryngoscope in their mouth wide, and their mouth is open wide enough for us to be able to access, and they might require an alternative method of managing their airway. So all things just to be aware of. The second thing is to be cautious. So when patients have risk factors for potential difficulty with managing their airway, they're coming out with kind of postoperative somnolence, like I talked about. Maybe they have multiple reasons for kind of an insufficient respiratory effort right off the bat. They may not be able to protect their airway as well as we would like them to. There are a lot of reasons, whether it's our anesthesia that's residual neuromuscular blockade, or opioid medications, which can be administered in the postoperative period. And so that combination can predispose patients to issues with their airway. And so again, just being cautious, particularly in patients with those risk factors. And then lastly, being vigilant, paying attention to potential for postoperative airway swelling, whether they have bleeding into the pharyngeal cavity. Patients who are hypoxic or seem to be in respiratory distress are again ones to just call for help sooner than later. And then I wanted to talk a little bit about neck mass and hematoma. Dr. Davis had let me know that there have been about 4 issues with neck mass and hematoma in the last couple of months. And so this is a really scary situation where patients develop a neck hematoma. Somebody who was not a difficult airway all of a sudden can become a difficult airway because now they have a mass that might be obstructing their airway structures, causing deviation from normal anatomy. And so I wanted to just highlight that, the early signs can be pretty subtle. It can be voice changes or hoarseness. Patients can be agitated or a little dyspneic, and those are all very nonspecific signs when patients are waking up from anesthesia. And so if somebody had something done where on their neck, and you're starting to see some of these signs, really looking carefully for a hematoma formation, and anything that's growing is really important. If patients develop stridor, that's a very late sign of impending airway collapse. And actually, stridor can often indicate very, very narrow airway to the point that they have less than 4 millimeters, which is incredibly small. And so being aware of it before it gets to that point is really important. And so calling for help early in anybody that you're worried about. And so other things I just wanted to touch on, patients who come out with a tracheostomy, you should always get information about the type and the size of their tracheostomy, why they had to have a tracheostomy, and there should be backup equipment. They should have an operator. Often they should have a backup tracheostomy here at their bedside. And if they don't come out with that, just making sure that we can obtain those things. Patients who have a laryngectomy, as you all probably already know, when they've had a laryngectomy, now you've separated the airway essentially from the naso and oropharynx. And so there is no way to access the airway from above. And so the only way to manage their airway is through that tracheal stoma. So that's just important to also just be aware of. And lastly, I will just leave some time for discussion and questions. That's some mountains, not where I grew up, not anywhere near here.
Where is it?
That's in Colorado where I grew up.
Oh, Colorado. You don't.
What other things can I clarify or answer?
I think that was definitely a really good overview.
Yeah. Thank you.
Your last 2 weeks have been good in the PACU. Any questions on Zoom? I don't know if anybody has anything.
me, it might have been someone that didn't.
There was 8 participants, now there's only, there's another iPhone person.
Oh, he's working in Boston.
So it's just Mills getting it, and I don't know what the other iPhone has.
He was a research scientist.
I've seen it.
You have?
I think
Why?
Yeah.
He's a research scientist. He used to work over, he never worked in the hospital. He used to come in and visit.
Like, oh, did he work at Pfizer?
No, he worked, the only time he's worked in the hospital